This video today is going to go over complex wound care, dressing change. So first off, what we would do, we want to do our hand hygiene. Normally, of course, I would be wearing a mask and in the lab goggles as well. However, I took off the mask just so you can hear me a little bit better. Okay, so after our hand hygiene, we would want to make sure that we check our physician orders to see how they would like us to do the dressing. As well, we would want to check if there's any analgesia that's ordered for our patient, because it may be a painful procedure. So after I've checked my orders, I'll also gather my supplies as well and head to my patient's room. Introduce myself. Good morning, my name is Rhonda. I'm going to do your dressing change today. Is that okay? Yes or no? Do you need anything for pain before I start? Yes or no? I can provide that analgesia. So I've just been in my patient's room, so I've touched stuff in my patient's room. I'm going to do my hand hygiene again before I do all my setup of supplies. So first I'm going to make sure that my overbed table is nice and clean. If my patient used it for lunch or breakfast, there may be stuff slopped on there, so I would have to wipe that down. I don't want that seeping through my sterile dressing tray. Okay. As well, I want to make sure that my overbed table is about waist height. Anything lower than our waist is considered not sterile, so we always want to keep our hands up when we're have our sterile gloves on. As well, we want our tray about waist height, and then our patient and or where we're working, we would like it about waist height as well. Sometimes that's kind of hard to do with our patients. The bed has to be moved up or down, but do your best. Okay. So after I've got everything all set up here, I can go ahead and set up my tray. You could, at this point, you could take off your patient's dressing if you wanted. However, then it's going to be exposed to air for a little while, and it could take me up to about 10 minutes to set up my tray. So I'm going to hang tight for a little while. My patient might want to roll around a bit more still, so I'm going to keep the dressing on until I'm ready to clean it. Okay? So this is a very well used dressing tray, so hopefully it's set up okay. So you can see you have your blue forceps in there. So now because I touched the end is not sterile. However, the tips are still sterile. I'm going to take this flap, the one and pull that farthest away from me, okay? Because I don't want to be reaching over my tray anymore once it's set up, okay? I'm going to move that where I think would be a good spot. Okay. Open that up. Open it up close to me. And also, remember, we're just grabbing our 1-inch borders there. So I could move that slightly. However, anything that has fallen over the overbed table, so underneath, is now considered not sterile. So I can't make it unsterile by lifting it up, okay? So if it's flopped over, it's not sterile anymore. Everything on my tray, right about here, within the 1-inch border, is considered sterile, okay? If it falls off my tray, then that's where my 1-inch border kind of starts. So I'm going to put those in my 1-inch border so that the tips still remain sterile, but the handles are no longer sterile. We have our garbage bag. You can use it if you want. Is it okay if I use your bed for some supplies? Patient says okay. Okay, and then we also have our extra drape here. So we can use that if we want. I'm going to put that here just in case I have any drips. I don't want to get the patient's bed wet. Okay? If you wanted to create more of a sterile field for yourself, you could use it as well. Remember though, this is now below my waist, so not considered sterile. So if I wanted to use it somewhere as a sterile field, I'd almost have to put it like up to my patient or over here. But I'm going to put it just down there. A lot of people opt not to use it. And then what I'm going to do is I'm just going to move this stuff around in my tray. So what I like to do is I like to make the nice big area, the big compartment, I like to leave it empty so that I can put my normal saline in there. And move all my tools. Now I will need 1 pair of scissors moved out to the 1-inch border because I'm going to use my hands, my non-sterile hands, to cut some new gauze. I'll show you that in a bit. So we push that out tip to tip. Okay, so that the tip still remains sterile, like that. Now I need to add a bunch of supplies. So I'm going to add a 30cc syringe. This one can be a little bit challenging to add. We can banana peel it back, and then we can drop it. However, sometimes it bounces around. If we want to make sure it doesn't bounce around, we can guide it out, put it where we want it. We're going to open up with a bunch of 4x4s. Remember, we're going to banana peel them back. And you can either drop them onto your sterile field, or you can guide them out with the forceps. We're going to make sure that we open them, not over top of our sterile field. There we go. Some of my gauzes look a little beat up. I'll use banana peel, drop. And some 2x2s as well, banana peel and drop. Add a bunch of those. Oh, that one I touched my finger. I'm going to dispose of that one. Banana peel and drop. If anything drops within your 1-inch border as well, should probably dispose of it. Banana peel and drop. And sterile scissors as well. So normally in clinical, these would be, you could banana peel them back. The packages that we have in lab are just Ziploc containers, so you just drop those on. There we go. We need 2 pairs of scissors for this, for the new gauze. And then we have our cotton tip swabs. We're going to use those for measuring. We can also use them for packing the wound. And then we also have our packing gauze as well. Again, in clinical, normally we would banana peel that back. We don't have that kind of packaging here in lab. So we're just going to, and I'm going to put it in the big container there. There we go. And drop it in. Okay, and then another package of the cotton tips. We're going to need 4 single tips, so 2 packages. 3 for measuring and 1 to help us with packing. And then if we wanted any more gauze, we can certainly add more gauze. Okay. I want to make sure that my ruler is visible here, so when I do my measurements later. We also need a IV Cathlon, so 20 gauge Cathlon. I'm going to show you later how we take the needle out of that. So drop that on. After you've used your needle, keep it, your Cathlon, keep it, and you can keep it without the metal needle, just in the packaging like that, okay? And that's how you can use it for your demo and for practicing, okay? We know when you've taken the needle out, that's fine. We're going to dispose of this later. Okay, so I think I've got everything, so I just have to add some new gauze. So this is a bit of the tricky part. So if our order says that we want to pack the tunneling with new gauze, it might say 1/2 inch or it might say 1 inch new gauze. That just refers to the width of it. If it's a bit wider, if it's 1 inch. I'm going to use 1/2 inch. So if this is a brand new bottle, this is really easy to take from here because it's all sterile inside. I would open up the container, break that little tab that tells me that it's all sterile. Okay, and I can take my sterile tip forceps, grasp that, and pull down. Sometimes this is a bit challenging to pull out, especially with the blue forceps. So what you can do, you can just try to pull that out. I might be near the end of the bottle of this one. Sometimes I wrap it around my forceps. It'll work. We're near the end of the bottle there. Oh, it's in a big clump, that's why. So if that happens to you, we can help you out with that. What I'm going to do, actually I'll show you how to dig and discard then since I'm having a lot of issues. Okay, so what I'm going to do is I'm going to end up discarding this. You can see it's all coming out in a lump. Okay. And that's a problem we have found with new gauze. Sometimes it's all kind of knotted inside. And that's fine if that happens, don't worry. We'll deal with it. Okay, wow, that came out in a big clump. Okay, so I'm going to, since I used with my hands, I touched it. I'm going to cut off the part that I touched. Because my hands weren't sterile, right? Now all of this part came from the bottle. So the assumption is this is all sterile. So I could use this for my dressing. And this looks like I pulled out a lot here. So over top of my field, I'm going to cut with my sterile scissors. So now all that is sterile, that can be packed into my wound, okay? And this big clump, I would be tempted in clinical just to toss this because this bottle is kind of a pain, okay? Now, if I had a brand new bottle, so because I had to take a discard from that one, so if I had a brand new bottle, let's see if this one works a bit better, I don't need to take a discard. There we go, that one works a bit better. Pull it right out and cut. This is brand new, okay? So now, because this is now used, the assumption is that this little tabby part here is not sterile because it's not in the bottle, okay? When I closed it last time, the potential is it might have gotten contaminated, okay? So what I would do is I'd have to take a discard, just like I did with that other bottle that was kind of a pain in the butt for me. Easiest way to do it is you're gonna take your fingers, and that one emptied for me. Let's grab a new bottle. Okay, let's see if this one will work a bit better here. Okay, so let's start again here. So this is a used bottle. I'm going to open it up here. So that little tab there has already been out of the bottle, so it's unsterile. Okay, I'm going to pull that out as much as I need. Okay. I want to cut off the non-sterile part. Okay. Oh, I accidentally put my scissors to the side. So what I would have to do then, I would have to grab my scissors here. And again, tip to tip, push them out. There we go. Okay, so I have to cut that discard off. Okay, that's a contaminated part. There we go. It's gone now. Okay, now this part is completely all sterile. I can cut that right onto my field. Okay, I'll put the cap back on there. Now, since I used those scissors, I might need them for my Curlex later. So what I would have to do is maybe add a new pair. Okay, so if I had yet another pair of sterile scissors, I could add a new pair. Alternatively, I can maybe ask somebody to bring me a new pair of scissors. They would have to be sterile though, because your hands might still be inside your sterile wound at that point. We can talk about that when we get there. Anyway, I'm going to add another pair of sterile scissors, okay? There we go. Okay, so now the only thing I need to add is my normal saline. We can leave all of that in there because we're going to get it wet anyway. Okay, my normal saline is over here. And very carefully, I'm going to pour it into my container here. I can saturate that gauze. Okay, and try not to make any drips. In practice, you may notice that some nurses still do a practice called lipping, is where they kind of tip out a bit of normal saline before they pour. It's not common practice to do that anymore. I think the rationale for that is the thought was maybe there might be some bacteria or microorganisms around the lip of this, and so pouring it out would eliminate that. However, we know if we put the cap back on here, this should all be still sterile inside. Okay, now that I've touched a whole bunch of supplies, I'm going to do my hand hygiene again. And I'm going to put on some clean gloves to take off this dressing. So now my tray should be all set up. I think I've got everything I need. I'm just going to take your dressing off and take a look there. So we would want to observe and see what are we pulling out. Okay. Is it saturated? What is it saturated with? Is there an odor? Now, this part is in the tunneling. This is the new gauze. So if I had a bit of a tail here that I could grasp, that would be great. I can pull it out easily. If I have to go dig for it, I might want to use some forceps. Okay, so I could use these blue forceps to kind of pull out that tunneling. However, if you do that, then you have to put your blue forceps into the trash. Okay, I didn't have to do that. I was able to grab the tail of it easily. So no problem. So I take a good look, see what I see here, and of course toss it, and toss my gloves as well, and perform hand hygiene again. Okay, so now I think I'm ready to irrigate my wound. So you could do this non-sterilely if you wanted. You would just have to make sure that your syringe and Cathlon are not on your sterile tray. I opted to do it all sterilely. Okay. May I use your bed just to put my sterile gloves on? We can open up our package here. And of course, normally I would like this bed to be a bit higher because it's below my waist. I worry that this would be unsterile. So you could use other areas as well if you wanted. Other than the bed, you could use the bedside table over there. Okay, so now I have some nice sterile hands, so I can start assembling my catheter, my 30 cc syringe. I'm going to pull up some normal saline. Okay. In the lab, we want you to irrigate with approximately no less than 10 cc's of normal saline. In the clinical setting, you would irrigate until whatever you're irrigating with is coming back clear. Okay, so that would indicate that you've gotten all the debris or any kind of sloughing. Now with the Cathlon, the 20 gauge Cathlon, it's pink. I'm going to take the cap off and we're going to get rid of the needle. Okay, so we're going to slide it right off of the metal needle. We're going to put that in the sharps container when it's convenient for us. So what we're left with is that pink plastic Cathlon. Okay? That's going to exert a certain amount of pressure onto our wound so we can irrigate it really well. Try to get some of that sloughing and debris off. Okay? We're going to attach that together. Then what we're going to do is we're going to irrigate the wound. We're going to start at the very bottom of the wound and work our way up. Reason being is because we don't want a puddle at the bottom. We don't want to irrigate a puddle. We want to irrigate right next to that tissue. So if we start at the top of the wound and go down, by the time we get to the bottom, there's a puddle at the bottom. And then that's not really effective, us spraying a puddle. So we're going to start at the very bottom. We're going to irrigate. The rule here is we're using a 30 cc syringe. We're using a 20 gauge Cathlon, and we're going to be about 10 centimeters away from our wound. And we're going to apply some pressure and irrigate. So 30, 20, 10. Easy way to remember that. We're going to irrigate all the way around the wound. And we would check to see if our wound care team wants us to irrigate that tunneling. Usually if you can't see the end of the tunneling, we don't irrigate it because we wouldn't know where this saline is going. If I was to shoot saline down there, there may be a pocket down here where that normal saline is going to gather and possibly cause an infection. Okay? So in lab as well, we're not going to irrigate the tunneling because it's hard to dry. However, there is undermining at the top of our wound. We can irrigate that undermining. So of course, you would just make sure that you know what your physician orders are or what the wound care team has suggested that you do. We're going to go all the way around the wound there. Again, minimum of 10 cc's normal saline, or in clinical until it runs clear. And then I can dispose of that when I'm all done. And then now what we'll do is we need our gauze to soak up all that water. The 4x4s are really good for that. And we can make our rosette by tucking in the four corners. I like a nice big buffer because we got a lot of normal saline to soak up, okay? So we're going to try to keep our tips of our forceps sterile. We're going to soak that up. So we do a dab and dispose. And then we repeat that. Do it again with another one. You could alternatively use your fingers with your rosette. However, you do want to keep your fingertips sterile. So you again would have to make sure that you have a nice big buffer. Some people have a hard time making the rosettes, so you can kind of just bunch it up like that. Okay. And we want to make sure we dry in our undermining as well. Okay, a dab and dispose. I do like using the forceps though. I'll be mindful of my 1-inch border there. I was getting pretty close. Okay, we're going to go all the way around the wound. Dab and dispose. All the way around. And the reason we just do the one dab is because I don't want to dab all the way around that wound and spread anything around that wound. Maybe there's some areas that are a little more dirty, and I mean, we should be fairly clean and sterile. However, I don't want to spread anything around the wound. Okay. there's any other wet areas I need to get to. And like I said, we don't need to dry our tunneling because we didn't irrigate down there. However, in clinical, they may have orders for you to put some new gauze in there to dry it and then take it out. I'll just dry the base of it here. Dab and dispose. So now that should be fairly clean, and now what I want to do is just clean my periwound. Okay, so I'm going to take 4x4s are good for this again, because they give you a nice bigger buffer, so that your forceps tips aren't going to get dirty. Okay, we're going to dip that in the normal saline, and we're going to go from our patient's head down to their bum. This part, of course, is probably the most dirty area of a patient because it's close to their bum, right? So we're going to start from the head, and we'll go all the way around here. We're going to go over top of that eschar tissue as well, because we do want to get anything off of there, if there's any contaminants or bacteria on there as well. Let's see, do I have more forceps? Here we go. Yeah, 4x4s. Again, dip, start at the head, and around we go, and dispose. Okay. Then we just need to dry that as well. Again, you can do this with your fingers if you want, as opposed to forceps. Just make sure you have a nice big buffer, okay, so that your tips of your fingers are not going to be contaminated. And you go over top and dry. Make sure you get over top of that eschar too. And another one to dry. Might do one more there. There we go. So now our wound should be nice and clean and dry. So what we can do now is we can assess the wound bed. Now that we've cleaned it, we can assess the wound bed. So we can look to see how much granulation tissue there is, how much sloughing there is. There's a little bit of eschar. So you can say in percentages if you want. It looks to be about 70% granulation tissue. Down here it looks like maybe a bit of bone. I'm not really sure. And then these other white areas look to be sloughing, so maybe about 20% sloughing. You could also say a large amount, moderate amount, small amount. I would say that this is a small amount of eschar around the periwound. So however you want to describe it is fine. The wound edges look nice and clean. They don't look macerated at all. They look nice and dry. So that would be the wound bed. And then we also want to take some measurements as well. So we can take some measurements, and because you're wearing sterile gloves, just be cautious that you don't touch anything. Okay, so we can measure the tunneling. Okay, and we have a ruler set up here. Okay, and some ways that people remember this is they'll break off the tip, and they'll put those aside so they have those for measuring. Some people just have a really good memory. You can ask somebody to jot it down for you. In lab, we're not going to expect you to memorize all these measurements. Okay? So that was the tunneling. Now, since I just stuck this into the tunneling, I don't know what it is at the end of that tunneling. So I'm going to dispose of this. This might be super contaminated. Okay, now in the undermining, same thing. I'm just going to slide my fingers to where the undermining starts and measure that and dispose. And then also, I'm going to do the length. So we can do that just by holding it up. There we go, a good distance, about 10 centimeters. Because I didn't touch anything with that one, I can also do the width with that one. So at the longest part here, and measure that up. That looks to be about 7 centimeters. Okay, and then lastly, again, I haven't touched anything with it, I'll do the depth. Okay, how deep the wound is at the deepest part, and measure that, about 3 centimeters. Now, since I touched the wound bed with that one, I'll dispose of that one. So now I have one extra, and I can use that for packing the wound. So I've assessed my wound. It seems to be all clean now. So now I can work on packing it. So first I want to start with the tunneling. And in your orders, the tunneling might be packed with new gauze, the skinny stuff, or it might be packed with Curlex. Okay, so just read your orders carefully. For this one, I'll do the new gauze. And you can pack with either forceps, but just make sure you're very careful. You don't want to poke your patient with your forceps. or you can use the gauze, or the cotton tipped. Okay, so I'm going to just drop that in there. I'm going to guide that in. And I soaked this with normal saline, and then I squeezed it out very carefully over top of my tray. If you happen to make drips on your tray, if it's large drips, you should probably get a new tray, because we worry that it's going to contaminate our tray. When the field is wet, stuff underneath will soak through, okay, and could contaminate your sterile field. Okay? If they're just small drips, I would just try to move your supplies away from where those small drips are. Okay, so now I've packed that tunneling. I've cut a lot of extra new gauze here. So I could trim that if I wanted, or because I'm going to have to pack the rest of the wound anyway, I can just let it sit inside the wound bed. I have quite a bit of extra there. This did not touch any of my wound bed, but if it did, I would discard it. Okay. And then next we're going to do our undermining. I'm going to squeeze out the excess normal saline. Okay, and again, you can use either forceps or you can use your cotton tipped. I'm going to go to the undermining. Just kind of guide that in there. It can be a bit challenging because the gauze sometimes sticks to your forceps. You could try using the opposite end, or you can try switching to your cotton tip. So you play around with it and kind of decide what technique you like the best. So just make sure you have good control of that gauze, packing it in. You'll notice I'm not going too high, I'm not unrolling too much at a time, because when I do that, sometimes it drapes over the periwound. Now, if your gauze touches the periwound, we did clean the periwound. However, remember, it's not sterile. We just cleaned it with normal saline. So there could still be some microorganisms outside on that periwound. And we don't want to track that inside our deep wound, right? Our wound that we're trying to keep sterile. So if you did happen to drape over and accidentally touch the skin, or touch a lot of the periwound, it would probably be best to get a new gauze and start packing all over. If you're near the end of your wound and that happens, maybe you have enough already filled inside your wound. So what you could do is just cut off where you contaminated and throw that out. So I want to make sure I fill this so it's not over full. It should be fluffy, and it should be about flush with the wound bed. And I don't want to see any of the pink or red tissue underneath. We're going to not cover that black eschar area because we want that to remain dry. It's not going to heal because it's dead tissue, but we want to keep it dry. There is a bit of sloughing that leads up to that black tissue. We're going to cover that because our hope is that maybe this gauze will dry, and when we take the gauze off, maybe the sloughing will come with it. Okay, so I have the perfect amount of gauze there, probably because I've used this one before, but if I didn't, if I needed to cut some off, I would take my scissors that are in my sterile field. However, I could use those ones as well, and I would just cut that off there. Okay, trim that, and those are still sterile. Now, if for some reason, and I see now I might not have enough 4x4s to finish my dressing change, if for some reason, say I didn't have that extra pair of scissors there, and I needed to cut my gauze, I could, now my sterile gloves are contaminated, I could cut. Okay, cut. Now, these are no longer sterile. My hands are no longer sterile. I could keep that there. Okay, so this hand is sterile. I could drop that in. Now I would switch to a no-touch technique. Okay, which I'm going to have to do anyway because I don't have enough 4x4s, I don't think. So my hands are no longer sterile. That's okay though, because the major part I needed sterile gloves for was for manipulating this gauze in there. Now, I'm just going to open these packages. Might be hard here with some gloves on. There we go. Banana peel. Okay, and I'm going to use my forceps. So now my whole tray is pretty much contaminated, but that's okay, I was all done with it. Lay that over top. I'm going to do the same thing with another one. Banana peel back. Lay that over top. And then my abs pad doesn't need to be on my sterile field. It takes up too much room anyway. I'm going to open that up. So I'm going to open it up so that one side remains sterile. So there we go. I haven't touched this side. It can go next to my patient, like so. And then we can tape that on there with some paper tape. Okay. And then, now that my dressing is done, I would make sure I want to document my findings on either the wound assessment sheet or a flow sheet, maybe write an IPN, and as well sign my MAR if I gave any analgesia.